Morning, everyone. Hi. Good morning and welcome. I'm Dr. Sue Borson, and I co-lead the Bold Center of Excellence on Early Detection of Dementia with my colleague and partner, Dr. Joshua Chodosh. We're so excited to bring you again today's webinar with Barak, Gaster, and Jackie Raetz from University of Washington. They are funded by CDC and by multiple other organizations to do the work that they do. We had them here, I guess it was about a year ago, and we're bringing them back now because they made so much progress in expanding and disseminating their work and developing the evidence base that supports it. Excuse me, a couple of reminders. This webinar is being recorded and it'll be shared with you by email and posted on our website. We'll have questions and answers after the session, so please put your questions in the Q&A if they're not answered automatically in the course of the conversation. It's really important to us that we know how we're doing with our webinars. Are we meeting your needs? Tell us about your experience. You'll be invited at the end of the session to take a couple of minutes to complete a short survey so we can continue to tailor our series of webinars to our audience. At the end, we'll share the survey link in the chat and the QR code on the screen. We're so glad you're all here today. First, let me introduce Dr. Barak Gaster. He's professor of medicine at the University of Washington, where he practices general internal medicine primary care. Over the last 7 years, he's become a national expert on dementia in the primary care setting, serving on leadership committees for the CDC Healthy Brain Initiative and on a Hastings Center work group related to bioethics issues in dementia. He's core faculty on the UW ECHO Dementia Program and a co-investigator at the University of Washington's Alzheimer's Disease Research Center. Dr. Jaqueline Raetz is an associate professor of family medicine at the University of Washington. She's board certified in family medicine, geriatric medicine, and palliative care, and continues to practice family medicine primary care, including outpatient, inpatient, and nursing home care. She practices at Harborview Medical Center, the main safety net hospital for King County, Washington, and provides care for a diverse population of underserved patients. So take it away, Barak and Jackie.
Right. Thank you so much for having us. And it is, let me get, there we go. And good. It is such a pleasure to be back and tell you about the work that Jackie and I have been doing over the past year or two, telling you about the Cognition in Primary Care program. And so without further ado, let me just give you sort of the big picture is that Cognition Primary Care is really designed as a quality improvement initiative, a practical, efficient model for primary care that's really all about facilitating detection and management of cognitive impairment in routine primary care practices, with just like the central sort of mantra that primary care providers really can make a diagnosis of mild cognitive impairment or dementia, and how incredibly important it is for them to do so, and that the key to helping them to do that is really giving them the knowledge and confidence on how to do it, that they can do it, that there are really important benefits to doing that, and that by doing that, it really is this easy intervention to get patients into care, because they really can't get into good care without a diagnosis. And so that diagnosis step is really a key part of cognition in primary care. We, like Dr. Borson has mentioned, we have been funded by the CDC, as well as by the Davos Alzheimer's Collaborative and the Gary and Mary West Health Institute. And we have no financial conflicts of interest to disclose. And, you know, I think really like the key sort of the seminal moment of cognition in primary care is the person who comes into their primary care doctor's office when a concern arises, you know, that for somebody who's like really pretty healthy, but for, for a number of reasons that I'll tell you about in a second, really a concern could arise that there might be something wrong with their memory or other cognitive domains. And that could be that the patient or family is bringing that concern to you as a primary care provider. It could be that the primary care provider has done some kind of a screening test like the mini-cog, or it could be that the PCP or one of the PCP staff is starting to be concerned about somebody who used to be on the ball and is suddenly having trouble. All of those things are reasons for concern, but they all lead to the need for an evaluation. And that primary care evaluation is the key to making a diagnosis, which is the key to getting somebody into good dementia care. And it's really the idea that that really can and should be happening in the primary care setting is so strong because, as we all know, there just are not enough specialists to do evaluations like this. Health systems want primary care on the front lines, in the trenches doing this work. And it's really what patients want. Patients don't want to be shipped off somewhere to be evaluated. They, ideally have a relationship with their primary care provider, and that's the person who they want and trust to sort of do this evaluation. And so, so what happens when somebody brings up a concern or when there is a positive screening test? Like should the PCP may very well be tempted to be like, oh, don't worry, it is normal to get more forgetful with age. And that's the old way of doing things that we are really, that's so 20th century. We're now in the place of where we are engaging with this disease and bringing and engaging with these concerns. Again, you're never going to be able to automatically refer everybody like this to a specialist. I think that the biggest sort of light bulb moment for primary care is do not try to sort of drop everything right then and there and try to do a cognitive assessment, because you will do not a good job and you'll blow up your whole clinic day. What you want to do is schedule an efficient follow-up visit to evaluate this further. And so the Cognition Primary Care Program is really all about giving primary care that workflow of how to do that in an efficient way with tools that support that workflow, with the big hook that this is actually things that you can do, primary care, to really improve people's brain health. You can, this is really not about the blockbuster drug that is sort of, we're all hoping to get soon, but it is the things that we can do in primary care to improve people's brain health and make their brains work better. So the Cognition Primary Care is really a quality improvement initiative that has 3 integrated components. The key center is the training. So we really want to give primary care the knowledge and the confidence through training, but it's quality improvement really cannot move forward with training alone. It's got to be paired and integrated with tools that primary care can use in their workplace. And so the 2 main categories of tools that we provide are tools in the electronic health record and tools in the exam rooms in the form of paper folders that we mail to clinics in the form of a starter box kit. So first, let me just tell you really quick about the training. The training has 3 main parts. Each is a 30-minute video series. First, how to evaluate cognition in the primary care setting. Next, how to set a plan for a newly diagnosed patient. And third, tips for managing mild cognitive impairment and dementia as they progress. And the framework for evaluating cognition is really with that when a red flag is raised. And so that could be the patient or a family have a concern. It could be a positive screening test. In any of those cases, the key tip is that you want to, again, schedule a dedicated visit for a cognitive evaluation. And then the other big light bulb moment for primary care is don't, if at all possible, don't try to do that with the patient alone. You're going to be so much more successful in doing that evaluation if you can get a family member or close friend to come to that visit. And again, this is not something that is intuitive to primary care. Most of the time, primary patients go to their primary care appointments by themselves. But this is really the reason where at that dedicated visit, you really want to try so hard to have a family member or close friend come to that visit if you can, to give that valuable observer or informant input. And so, the big light bulbs for primary care is, wow, there are things I can do now. The brain health changes I can make help happen, getting that family member input and really making your job easier. That when patients are drifting in and out of our clinics, in and out of our health systems with unrecognized cognitive impairment, and people are not remembering half of what you're telling them, it leads to chaos and frustration. And that really we can make primary care jobs easier, we can make health systems work better, and we can make patients' lives better as well by making this diagnosis. The 3 parts to the dedicated visit are a cognition checklist that I'll show you in a second, which are really all about these like reversible things, factors that we can easily fix in primary care, assessing cognitive functions such as with a MoCA test, and then getting input from an observer or an informant. I really hate to use the word informant when I'm talking to primary care audiences because it's such a stigmatizing word. It sounds like you're ratting somebody out. And so really, I think the word observer makes so much more sense to primary care. And there we suggest using the 88 questionnaire. Here's just a quick look at what our cognition checklist looks like. The labs that people generally remember from school, but the real light bulb moments are look at their medication list, identify especially anticholinergic medications that might be affecting their thinking, and don't forget to ask about over-the-counter medications like diphenhydramine, which is probably the biggest unrecognized cause of cognitive impairment in those over age 65. Don't forget to ask about alcohol. And again, this is not somebody who necessarily has an alcohol use disorder, but somebody who has been drinking, 3 or 4 or 5 drinks a day, which has been too much, but not enough to functionally impair them their whole life. But now that they are 70 and are worried about their cognition or not scoring well on a mini cog test, telling them that reducing their alcohol intake really can make their brain work better. And then comorbidities that really primary care does this all the time, but like making that link that this is actually brain health by helping people to get better treatment for sleep apnea, hearing loss, and depression, their brains will work better. We create that as a simple text-based checklist that's easy to add to any EHR. And really making a diagnosis of mild cognitive impairment is something that primary care can do, and we give them a playbook for how to do it. Putting the cognitive test result together with the informant input as really that key to opening the door to getting them into better care, and we'll talk about that in a second more. And when we have presented this to primary care, I think the key is that both Jackie and I are practicing primary care doctors, and so we're able to talk to primary care in this very sort of meaningful way that resonates with primary care, because Jackie and I are both sort of understand how hard it is to be a primary care doctor, and so people really have appreciated the value of and quality of the training that we've been able to give them. But again, it's more than just the training. We really want to integrate that training with tools in the electronic health record. So we embed that cognitive checklist in the EHR. It's a simple text-based checklist. And so we built it in Epic, but it is so simple that it really can be easily implemented into other types of EHRs. We can embed it as a single folder or smart set where there can be 2 or 3 or 4 of these tools in one place that are ready for people to find as they're seeing patients. And again, that starter box kit is so important because we are still in a place where for most primary care clinics, it's going to make the most sense for them to do, say, a MoCA test on paper. So drawing the clock on a piece of paper. And so people are really still, like every primary care clinic still has a place where there are folders with paper in them. And so what we do is we have developed a box kit that we mail to a clinic manager ahead of the launch of the implementation, where they can make sure that these paper folders are in place for their primary care doctors to have access to while they're seeing patients. There are 3 different folders that we mail to them, and there's also actually a printed playbook that they can give to each primary care provider in the clinic that really is sort of makes the training go so much smoother and better because they have the tools in place that we present in the training. And so I'm going to turn things over to Jackie, who will tell you next about what the next steps are after that.
Yeah, so when we designed this, we heard loud and clear from primary care that, it wasn't enough just to evaluate cognition and start to make a diagnosis. They needed information what to do after that, and that includes how to talk to them about a diagnosis, how to refer to community resources, and how to manage cognitive impairment and dementia as it progresses. Next slide. So in our second part of our three-part series, we use a lot of training around discussing serious news, recognizing that many patients, large percentages of patients and their families don't remember ever being given a diagnosis of dementia, so it needs to be not just a one-time conversation. We also know that primary care wants to know about not just the older drugs that have been on the market for a long time, but the newest anti-amyloid drugs, and continue to promote brain health even after diagnosis. We really see our program as synergistic with the guide model that many healthcare systems are rolling out. A diagnosis is really necessary to get them into that interdisciplinary care that the guide model provides. And like Barak said, getting every single person who screens positive into specialty care is not practical for most healthcare systems. So we'll share briefly the data from our pilot here, or our not our pilot, but our healthcare system. So we implemented the Cognition primary care program across a network of 14 community-based primary care clinics. These were not academic clinicians. These were full-time primary care providers. And it was the clinics provided a very diverse care for a very diverse patient population, with 41% identifying as non-white. And we showed that rolling out the Cognition in Primary Care program resulted in more cognitive assessments done as measured by number of Montreal cognitive assessments entered into electronic health record during the course of the program. And excitingly, also increased the number of diagnoses of mild cognitive impairment within the primary care setting. I'll turn things back over to Barak.
Yeah. And, and just to kind of make just a quick point about this slide is that this is not necessarily like early diagnosis, it's just diagnosis. I think that people with mild cognitive impairment, like that is the core target group where we can really make the biggest difference in improving and maintaining people's brain health. And so, as Jackie said, we're now at the end of rolling this out to the 14 clinics in the UW medicine system. And we're at this like very pivotal, exciting point of packaging what we have done here and making it something that can be easily disseminated to other health systems. And so the three parts of this package are really like concise CME. And so we are like really moving somewhat to think more broadly than just the live webinars that we've been giving, because what we heard from the PCPs is like, oh my goodness, I'm so sorry that I missed that session. Do you have a recording of it that I can watch later? And so really thinking of developing really high quality recordings of the training that people can stream on their own time, as well as an e-learning module that we actually do have up on the CDC website, where people can actually sort of go through a really expanded version of our slide deck if that is the style of learner that they are. And that is paired together with an EHR implementation guide, instructions for adding the text-based checklists into really just about any EHR. And then again, the starter box kit I mentioned that is mailed to a clinic manager to help the clinic manager put the folders in place and make it easy for PCPs to put the training into practice. And so right now we are just about to get funding from the CDC through the Washington State BOLD grant that they have given to Washington State to partner to bring this to federally qualified health centers in the state of Washington. We also are just signed a contract with the American Academy of Family Physicians to put our training onto their learner platform. Over 130,000 family medicine members around the country. And then we're going to then find a subset of their members who are really interested in taking it a step further through their office champions model to bring the other components of cognition primary care to their clinics. And then we also are just in 2 weeks now are officially launching cognition primary care at Houston Methodist, which is a large accountable care organization. Tufts is extremely interested in the work that we're doing, and we're pretty far along in conversations with them. Hope to collaborate with Penn in the future, which is also like very far along in engaging with their primary care workforce. And we also have 2 programs ongoing with the Indian Health Service and the NIA to bring cognition and primary care in an adapted way to clinics that serve large numbers of American Indian Native Alaskans. And so that is the Cognition and Primary Care Program in a very quick nutshell, and happy to have a conversation about it, and really want to thank you all for being here with us today.
Wow, that's really, that's an amazing update. You've done so much in the last year since we last had you on our show. You know, the title of this talk was originally Embracing Our Values. And this came from the idea that primary care really is the segment of our healthcare delivery system where whole person care is a top priority. So I wonder if you could comment a bit on the how you integrate this with whole person care over the course of dementia. That could include things like the cadence of care, what you consider to be really within the purview of primary care as opposed to what really belongs somewhere else. We know that there aren't enough specialists, but there's more to it than that, in that specialists in cognitive disorders typically have not taken on the challenge of whole person care. They do a fantastic job with diagnosis and differential diagnosis and some of the more refined aspects of, say, infusion therapies or being able to distinguish a really rare type of brain disease from something that's more common, you know, ordinary vanilla dementia. So how do you see primary care evolving this as a whole person model over the lifespan? Now that isn't as big a question as it might sound.
Yeah.
It's really what you do every day. So tell us about that.
Right. And exactly, that's, I think, you know, Jackie says it so well. Like I've heard she has like this like wonderful slide that she puts up of like, you know, this is primary care's superpower. You know, this is like what and this is like what resonates so much with primary care audiences when we talk to them, because this is like what primary care wants to do. You know, primary care really is feeling like stuck and inadequate when it comes to cognitive impairment, and really does want to embrace the concept because they are already doing this. You know, I mean, the vast majority of dementia care is actually happening in the primary care setting right now. You know, it's diagnosed too late, but it's eventually does get diagnosed, and the care is at least beginning in the primary care setting. And so it is like the value of the, you know, chronic disease management, sort of like whole person, and then the phrase that you have used and taught me so wonderfully, Sue, is, you know, just like thinking of dementia as the sort of organizing principle for somebody's care. You know, that when we don't have it diagnosed, the other comorbidities, the other sort of chronic diseases that people have are just like not being managed well without the realization that you really do need to consider their cognitive impairment as that like holistic part of their care.
I think the other thing that primary care does well is patient-centered care. You know, we have best practices for all sorts of diseases, but it doesn't mean that every patient is going to want to take a statin, even if it's recommended. And so I think there's a lot of branch points and choices in cognitive care, and that includes, do you want to see if you're a candidate for these newer medications? Talking about advanced care planning, what kind of care would you want if you became, seriously ill? And so, primary care, we provide patient-centered care. We find out what is important to patients and their families, and make sure that the care that they get is aligned with their goals and values. And so I think that's another reason that this fits well in the primary care model.
So we found in a study that we did in Southern California that there was a big bump in the completion of advanced care plans, this end-of-life care planning tool that healthcare systems are prioritizing increasingly over time. Big bump in completion of advanced care plans in the chart right after a dementia diagnosis. So, it's kind of unfortunate that it takes that to get advanced care planning on the radar, but I wonder if you've noticed any other kinds of changes, either through your data acquisition or through just your impressions about what happens after people go through this process with their primary care clinician. How do things change?
Yeah, I mean, advanced care planning is a huge part of our part three. Part three of our training, is managing mild cognitive impairment and dementia as it progresses. Advanced care planning is a really key component of that, and for that, I think it's also acknowledging how complicated advanced care planning is for dementia. That's like it's its own very special and important sort of segment of the field of advanced care planning. But the big hook that really does resonate with primary care when we talk about it is how important it is to identify a durable power of attorney like early in the course of a cognitive impairment disease. Because it is just so important to identify who's the backup to their sort of obvious person. Their obvious person is most often their spouse. And in the course of a 10-year dementia illness, it is very possible that their spouse is not going to be there to be their surrogate decision maker as they get to advanced dementia. And at that point, they will have lost the capacity to identify who the backup to that person is. And so it's just such a golden moment to teach primary care, try to get a durable power of attorney for healthcare early in the course of mild cognitive impairment. And I think, so we have definitely seen that. I think the biggest impact that we have also kind of anecdotally seen is an improvement in the quality of referrals that go to specialists. That I think the default can be that anybody who has a concern just automatically gets sent to a specialist, and an awful lot of those people are the worried well. They're cognitively fine, and they are really it's taking up a lot of space. And like I had a meeting 2 weeks ago with our memory clinic here at the University of Washington. There are 1,000 patients on their waiting list right now. They have 1,000 referrals that they are sort of buried under, and to improve the quality of those referrals, people who have already sort of been evaluated for other conditions other than neurocognitive degeneration, who have had a MoCA test, like that is really an incredibly valuable thing to a health system to improve the quality of those referrals.
So let me mention that Don Scott, who's one of our member of our audience, is asking, at what point in terms of diagnosing and treating should the PCP refer to a specialist?
So I think we definitely addressed that in our training, but it's not a one size fits all. We emphasize red flags that we recommend a more urgent referral if there's any early visual hallucinations to suggest Lewy body dementia, if they're very young, if there's rapid progression or atypical neurologic symptoms. And then I think it depends on your healthcare system, the availability of specialists, and then patient and family preference. If you have a 90-year-old who's well cared for by extended family, Clearly, by even clinical history, seems like they have Alzheimer's, dementia, not interested in taking any medication. Specialists in our system don't always want to even see those patients. And so it's really a case by case, talking with the patient and family, seeing what they want, seeing, what your own comfort level, because there's a wide variation in comfort level with diagnosis and treatment amongst primary care providers. Some primary care providers have very young patient panels. They see maybe mostly kids and young adults. So they might see this once a year or once every few years. Some providers like Barak and I who have been around forever have a very large geriatric patient population, and we see this quite frequently. So it depends on the physician's comfort level in diagnosis and treatment as well.
So let me
like
just,
Jackie,
go
and
ahead.
just like Jackie said, like where they're practicing. Like if you are, in a metropolitan area where there is a Alzheimer's disease research center sort of around the corner, like that's one thing. But if you are, in a sort of remote sort of part of Washington State or, Nevada or Wisconsin, where it's a 3-hour drive to get to a specialist, that's going to be sort of a different clinic setting right there.
So I want to emphasize kind of an element of the system in which people are working. One of the things that we found in projects with primary care clinicians is that they don't always feel that specialists meet their needs, that a specialty evaluation and report is something that they can actually use. And so we've started to think about how to bring together the specialists and primary care clinicians within a given institution or practice setting to negotiate their respective contributions to the care of people with dementia as a population health strategy. So is this something that's happening at University of Washington?
I mean, when you say that, I think of what a lot of primary care doctors need is the guide model. They need specialty social work, community resources, families need respite care, patients need in-home caregiving, which is not always what the specialists, they may give a very specific diagnosis and they may or may not have access to helping families obtain those resources. So I think your question was, are we doing that? We are not. We have not signed up as a guide model as of yet. We do have some social work support in our system, but we could definitely use more. I don't know what you want to add to that, Barak.
Yeah, I mean, I think the guide model is the most exciting thing that's happened in the field of dementia care, in my 30-year career, without question. And I really do see that, as more and more places have access to guide model type care, it's just the value of training primary care to make this diagnosis just increases even more because patients need that diagnosis as the key to getting into that care.
So there's some questions where I'm looking at the Q&A here. It's a very active Q&A. Let's pick this one. Dr. Gaster said MCI, mild cognitive impairment diagnosis, is the most effective point at which you can impact the most people. Are you also saying that it doesn't make sense to screen for MCI if patient doesn't show any cognitive concerns? Should a primary care provider only respond when a cognitive concern presents itself, either from the patient or from a family member or from a clinician?
Yeah, and so I could talk for an hour about sort of the pros and cons of screening. Incredibly sort of complicated sort of box of questions, and I think the main sort of message of cognition in primary care is to sort of rise above the controversy of should we be screening or should we not be screening, because yes, there's like good reasons to screen and there's good reasons to be a little bit sort of cautious about screening, but like regardless, I think the amount of energy that we are spending sort of worrying about that controversy is missing like the elephant in the room, which is that we just can't, we don't have good mechanisms for getting people a diagnosis if they screen positive. or if they have a concern. And so I think regardless, and so that's like that slide I show where it can be a PCP concern, it could be a patient or family concern, or it could be a screening test. Like all three of those all kind of like lead into the big giant bottleneck of our health system, which is lack of evaluation, lack of a diagnosis for people who really can benefit a lot from having a diagnosis.
We found variation within our own healthcare system. Some clinics are doing universal screening and some are not. And we recognize we're the step after screening. So, the more people that are screened, the more people you can get evaluated.
Right. So say the annual wellness visit, that's not what you're talking about. And you're talking about even if there is a wellness visit and there is some kind of, there's detection of possible cognitive impairment, that's where your program comes into play. Okay.
Yeah.
So
We do. We definitely anchor in the Medicare annual wellness visit though, because that is like those three things that happen, either the patient concern, PCP concern, or a positive screen. Those are three things that will often happen at a Medicare annual wellness visit. And so we really do sort of, in some ways, anchor the sort of the beginning of our workflow right there. Because most of the time when people are in for their follow-up of their diabetes or their hypertension, this may come up at one of those visits, but the place where it is more likely to come up is at the Medicare annual wellness visit.
Okay, that's really important. I'd love to spend more time on that, but I know we have so many questions in the Q&A. Many of these questions have to do with, hey, how do we get these kits? How do we sign up? How do we get the training? And what does it cost? So you want to address those?
Yeah. And so, we are definitely, in like an active wanting to give our stuff away for free. I think, the funders that we have had, the CDC, the Davos Alzheimer's Collaborative, the West Health, they are very keen on funding us to create sort of, nonprofit, low cost, sort of easily disseminatable tools. And so you should definitely email us at cog-evaluation, cog, I'll put it in the chat if I can. Let me share with my screen again really quick.
And maybe sharing our website, both our email is on our website. We did with the CDC create an e-learning module that is available. You do have to sign up for a free username and password with CDC Train. But you can see the content of our training if you're curious on that. And soon we'll have the videos as well also available, but they are not currently up on the website yet.
Yeah, but so to answer the question, we are at this pivotal moment of really wanting to have this packaged quality improvement initiative available to health systems around the country. We do think of it as a relatively easy lift, plug and play kind of solution, that it doesn't require a health system to hire health navigators, which is, not to say that that's not a really, really good sort of possible solution, but it's not the solution that some health systems necessarily want to take on, because sometimes it is hard to find the health navigators to hire, and it's sometimes hard to retain them, and health systems are sometimes hesitant to take on the long-term financial commitment of adding staff like that. And so the Cognition in Primary Care program can definitely help to facilitate a model like that, where there is you're hiring staff like a health navigator or brain health navigator, but also can work really well just in an existing sort of primary care system to train primary care to do what they want to be doing and give them the tools to do it.
So I'll just comment that the three bold centers, early detection, risk reduction, early detection, and caregiving centers are working on a set of core competencies for community health workers. And we think of community health workers in kind of a larger frame, not just referring to people from underserved communities who are members of that community and have the trust of their community who can function as liaisons, for example, with healthcare and social care services. We're trying to help develop this role on a national scale. Brain health navigator, community health worker, multiple different terms for the same kind of role. Fundamentally, somebody who does not have to have a license to practice healthcare in any particular discipline, but who can really learn a very specialized role like this, like the guide role or a pre-diagnosis navigator role. So this is something that we're working on as a center, and we would encourage our listeners to follow along with us on that through our website. There's a question about reimbursement. This one is an easy answer for you guys. When you have identified a concern and you have done your initial brain health assessment, right? And that, or you've identified the concern and you're moving into a more detailed evaluation. How do you bill for your more detailed evaluation, and do you want to talk about what it includes?
Yeah, so
Besides the checklist that you have shared.
Yeah, so and this is a question that I get a lot and has struggled with a bunch. And and I think that the Medicare CMS code for evaluation and care planning for dementia is a very, very complex code. It is a code that has it's 16 pages long of all the things that are, and every single one of them is required to do to bill for that code, and it's a huge revenue. I mean, it's like the RVUs, which is like the revenue sort of scale for how much you get for that code, is very, very high, but it really is designed to be like a 60-minute visit, which is really, really, really difficult for a primary care setting to squeeze in. And so the way that we sort of generally approach this is that you can do this in your standard sort of visit slot, but you might do it over 2 or 3 times, 2 or 3 visits. And especially when it comes to the developing the care plan process, that's something that could sort of be an ongoing thing that takes 6 months or 12 months. And it's going to be really difficult to bundle it into a single giant Medicare code. And so the way that we really train is to use the level 5 E&M code, the Evaluation and Management Code level 5, which is something that primary care is very, very good at and used to doing. And it's been such a really good dramatic change in the way that Medicare has defined those codes when used for time-based billing. Because this is a time intensive process. I'm so sorry that we're having a fire alarm here, but I don't think it's a real fire.
We can't hear it.
But okay, good. But so that we are like thinking of this as a time-based code where if you spend more than 40 minutes on a visit, that doesn't have to be face-to-face time. It's time that you spend preparing for the visit and documenting at the end after the visit as well. If that takes more than 40 minutes, which can be fit into the usual sort of short length of a primary care visit, you can get enough RVUs that if you do 3 of those, you're going to get dramatically more reimbursement than you will for even that single large CMS Medicare code. And so I really, and you have so much more flexibility in terms of how much time does that have to occur, and do you have to sort of hit every single one of the 16 pages that are in the requirements for that larger code. And and then we're also very, very big on adding the advanced care planning code to the Medicare annual wellness visit. We give the very, very concise, easy sort of guidance on how to do that. That's especially good for somebody who has a diagnosis of mild cognitive impairment or dementia. You still want them to have their Medicare annual wellness visits, but you're going to spend more of that time talking about advanced care planning than you're going to talk about mammograms or colonoscopies. and can double the number of RVUs, the reimbursement that you get for a Medicare annual wellness visit, if you add the advanced care planning code to that visit.
So I would say this really, your way of thinking about this, Barak, comports perfectly with, I think, what most people think. The CMS's cognitive assessment and care plan code was a wonderful innovation, but it doesn't seem to work well in actual practice. It's just too hard. And as many PCPs have said to me, it isn't the way we think. We don't think
Yeah.
like this. And so the approach has to fit with the way primary care practitioners typically do think about what they do and what their patients need. So, we
And
go
some,
on.
yeah,
Oh, yeah, go ahead.
and so, somebody who works in a geriatrics clinic or in a memory care clinic where they're going to have a very high volume of visits like this, then it makes sense to build out an elaborate process where you can automate a lot of the components of that visit. And if you're doing it in a high enough volume, then it's going to make sense to build all that infrastructure for that visit. But in a primary care setting, it's just it's too, the juice isn't worth the squeeze, or the squeeze isn't worth the whatever,
Yeah, the juice is right,
yeah,
right.
it's too
Squeeze it
much.
too hard.
It's yeah. And primary care has finally sort of like gotten to the point of doing that for the Medicare annual wellness visit. There was a lot, it took years and years for the Medicare annual wellness visit to really become like a more or less standard part of primary care, because there are so many complex components to it. But because like every Medicare beneficiary needs that every year, that's a high enough volume that makes building that infrastructure to make that visit possible. That's just not there for the dementia evaluation and care planning code.
Well, a little caution on that before I get to what will probably have to be our last focus area, and that's about the fact that annual wellness visit is a really good idea. But it's still not used by more than, it's what the most recent data say 30-40% of people are getting wellness visits. But we don't need to dwell on that. It's just, it hasn't been as widely adopted as I think CMS was hoping for. But a really important domain here, and I know you're moving into this area, and we are in Southern California, and I know Josh is in New York too, and many places, and that is, you've been talking about fee-for-service patients who are really in a fee-for-service Medicare environment, like most academic medical centers and many practices outside of academia. So what about those that are not? Those that are part of a federally qualified health center, a community clinic setting, a rural health setting where there's a fundamental difference in the way care is paid for and thought about. And so talk a little bit about implementation of your program in those kinds of environments, FQHCs, community clinics, and the like.
In
Jackie?
my limited knowledge of FQHC billing, a lot of times it's really just almost per patient seen. And so even more so, they need to break up this evaluation over several visits. They may not be able to do more than a 15, 20, 30-minute visit. And so, our model where you can break the whole evaluation and care planning over several visits is going to work well, because they'll never get a 45-minute or a 60-minute visit, and they're reimbursed per patient seen. And so seeing them more frequently is going to be the way they're going to have to make this work.
Right. For those in the listening audience who are not familiar with this, it's, it's a little crude, but the way I think about it is you can come in with a stubbed toe, or you can come in with dementia, and the reimbursement is going to be the same for that visit. And so it's like there are some barriers here, and this has to do with a specialized funding for rural and federally qualified health centers that were designed, of course, to increase access to care. So they're a wonderful innovation, but there are some special things that need to be done. to implement a dementia detection program within FQHCs. That is happening, nevertheless, and it's happening in Washington, it's happening in Southern California, it's happening in New York, it's happening all over the country where people are tuned in to the value of detecting dementia as, let's say, an organizing principle of care, so that you don't get caught up or caught out by the consequences of dementia creating chaos in your healthcare delivery for that patient.
And
So
it brings up the other really important sort of direction that we're hopefully all sort of like, you know, swimming towards, which is value-based care, you know, away from fee-for-service for, you know, not just federally qualified health centers, but for large health systems as well, where I think that like a lot of the Medicare Advantage plans are really sort of driving that sort of shift. You know, Medicare has, you know, created this really exciting pilot program called Making Care Primary, which is really sort of like to sort of invest in trying out value-based care in the primary care setting. And the guide model is like completely built around, you know, moving us towards value-based care, where the bean counting of an office visit becomes less the coin of the realm, and instead the coin of the realm is what are called HCC codes, which are these complexity diagnostic sort of values that are sort of attached to a patient that really help a health system to estimate what is going to be the cost of caring for that patient in a holistic way over the course of the next year. And, you know, one of the other big things that that Cognition Primary Care is really working for is to really make mild cognitive impairment become a highly valued HCC code, which it currently is not. But we, you know, Jackie and I met with you know, very, very high up people at CMS last month who were very receptive and interested in making that change. And I think that is going to be a really, really important step to taking cognitive impairment sort of diagnosis and care into the value-based care era, which is, I think, where we are headed.
great. So I know that we are coming up close to time, and I think there are. We've tried to address most of the questions that have come up, not all of them. I'm trying to choose the ones that probably apply most broadly to our listeners. But I do want to touch for a moment on the question of hearing. You know, you call out hearing loss as an issue in the cognitive assessment, and we know there's a tremendous literature on this now, and there's continuing interest and controversy as to what is the relationship, what are the many relationships really between how the brain works and how the ears work. And but one of our attendees is asking about, besides hearing aids and cochlear implants, is there anything else you think about when you're working with people who are hearing impaired? Anything, any research on interventions that you're aware of, anything that you do in primary care?
The ruminant action.
Oh, yeah, so we can remove earwax. The audiologist doesn't like it when we refer them and don't remove the earwax first. I mean, sometimes we're really even lower tech than, you know, what I mean, some places that people can't afford a good hearing aid, or they might not have resources, and we're talking about $15 pocket talkers just to make sure that the patient can hear us when we, you know, change one of their diabetes medications. So primary care is often much lower tech.
Yeah, and people people, it's not that people don't have hearing aids, but they just don't wear them. You know, and so I think that's like that's the like the light bulb moment for primary care of like, oh, there's like something I can do. It doesn't necessarily mean that I have to put in this referral, or I have to, you know, convince them to buy a hearing aid, but just making that point that your brain will work better if you wear your hearing aid more. that in the same way that reducing your alcohol intake will make your brain work better, wearing your hearing aid will make your brain work better, because I think it is, my father-in-law was very, very, very hard of hearing, to the point that it was really hard to really even say what his cognitive function was, because he was just so completely isolated from the world. And so I think just making that connection, that like chicken and egg phenomenon of the input helps your brain work better, and then your brain working better helps you to sort of interact with the world better. That brain health message for primary care really, really makes sense to primary care, and that moving beyond just heart health to also talking about brain health, and that hearing aids are and wearing your hearing aids regularly are a really important part of brain health. That's the kind of thing that primary care loves, and like, I can run with that. I can do that. Thank you.
But recognizing too, with patient-centered care, there's still a stigma. A lot of people don't want to wear hearing aids. They don't want to use their walker, and they don't want to wear hearing aids. And so, acknowledging that, just having ongoing conversations is really important.
It's also possible to encourage people to be, a new version of Gray Panthers, and say, this is who I am. So the destigmatizing movements that are happening around the world are things that we should all embrace and push for. Aging pride. Okay. So I know that we are just about out of time. This audience has been absolutely incredible. Can't keep up with them. Thank you all for being here.